Hello, everybody, and welcome to the webinar, the Neurological Associations of COVID-19 webinar. This is our monthly webinar. We've been doing them for several months now, and it's a production of the University of Liverpool's Brain Infections Group, our Brain Infections Global Programme, the COVID Neuro Network, supported by the Global Health Network with our partner, the Journal of Neurology, Neurosurgery and Psychiatry, as well as the World Health Organization. Enough of that. Just a bit more about the Brain Infections Global program, which supports these webinars. So this is the web page. If you've not visited it yet, you'll see on here the COVID Neuro pages, which have things like case record forms and previous webinars and links to other important things, including our adverse events reporting forms, if you're interested in that. We also have on here the links to the training modules, such as the free online neuro e-learning training modules, and links to the Liverpool Neurological Infectious Disease course, which we're hoping to run again in person this year in July. It's already oversubscribed, but you could always add your name to the waiting list if you're not on there, and we'll see what happens with that. So the Brain Infections Global is part of the Global Health Network here. You can see we have 19,000 visitors and 1,800 members. That's just on our BI Global website. The Global Health Network has many more than that. These are the main countries you can see here that link into the network, and it's an environment for learning, joining events and accessing resources. So the purpose of these webinars are to bring together the global community working on COVID neurological disease so that we can better understand the neurological presentations and complications and long-term effects, as well as disease mechanisms. And it also allows us to keep up to date collectively with the latest research. And then immediately after this webinar, we have the WHO Clinical Exchange Network. So our speakers today in the webinar are Professor Clarissa Lin Yasuda, who's a neurologist from the University of Campinas, Brazil. Then we have a short break during which Danish Hafiz from the University of Manchester will be presenting the highlights of the JNNP blog, and that's really a great way of keeping up to speed. And then we've got Professor Paul Harrison, who's a psychiatrist at the University of Oxford, who's going to present these data recently published in the Lancet journals on bidirectional associations between COVID-19 and psychiatric disorders. And as mentioned, immediately after that, we have the WHO COVID Neuro Clinical Exchange, which we'll be hearing more about shortly. So you can please post any questions or comments you have. It's easiest just to use the chat function on Zoom. Also, we're live on Facebook, and you can, if you're watching on Facebook, you can post comments in there, and we'll try and keep an eye on those and introduce them. That's my Twitter handle at the bottom there if you want to keep in touch after the webinar. Great, so I'll pause there and hand over to Clarissa Lin Yasuda, who's going to present to us her fascinating data from Brazil. So Clarissa, if you want to turn your video on and
yes,
start sharing your screen. Did I share my screen then, or did I forget to do that? I was sharing my screen, was I?
Yes, you were.
Okay, great. All right, so Clarissa, if you want to share your screen.
Is that okay?
That's perfect. Yeah, we've got it. Brilliant. Thanks very much. Actually, before you do that, sorry, Clarissa, I forgot. We're always interested in where people are watching from. So just whilst we're handing over, if you want to post in the chat function where you're watching from, where in the world, and whether this is your first time or you're a repeat offender, then please do. And that usually warms the chat up. So then we can post in lots of questions and comments later on. But great, Clarissa, over to you.
Okay, thank you very much for the invitation. It's a great honor and pleasure to be here to present our data from this Brazilian study. And so just to be clear, this is a huge group that worked together to get this study. So I'll be talking in the name of a large group of researchers, okay? So the motivation that drove us to start the study is because at the beginning of the last year, we saw a lot of reports telling us about the neurological involvement in the new infection. And then we raised some questions. Does the SARS-CoV alter the brain? Does it reach the brain? How does it reach the brain, and what can it do to the brain? So as Professor said, this has been submitted and it's now under review, but has been submitted to is in a preprint where we can see most of these results. I'll try to split my agenda now in two parts because we have some in vivo data and then some in vitro. So, and I will start talking about my part, that is the in vivo study. And we have some clinical data, some cognitive analysis, and some MRI analysis as well. So this is not in the preprint, but I thought this would be nice to bring because we start everything with online survey. And right now we have over 7,000 entries in this survey. And we just run a quick analysis, and then we saw that from this cross-sectional study, and it's important to say that most of these individuals, from the 7,000, they have not been hospitalized. So most of them had home treatment only. And if we look here over the time, we see some of the symptoms, they do not appear at the beginning of the infection, but they start appearing and remains over time, like fatigue, memory, and cognitive headaches, difficulty with daily activities. And this is what we have been seeing in our patients here. But talking about the people we have brought to the hospital and interviewed, at the time we submit the preprint, we had evaluated around almost 200 subjects with personal interview, neurological examination, MRI, and some neuropsych as well. And again, I want to be sure to tell that they have not been hospitalized and they have been evaluated almost 2 months after the infection. We also collect some questionnaires, and then we evaluated fatigue and somnolence, the excessive daytime sleeping, and we observed a high frequency of both these symptoms. In addition, it was interesting for us to see that after almost 2 months from the acute stage, most of the individuals, they persist with a lot of symptoms. So each column is one subject, and most of them complain about a lot of problems, even after 2 months of the acute stage. From our neuropsychological evaluation, we also tested some anxiety and depression, and we observed anxiety symptoms in almost 30% and depression symptoms in almost 20% of the individuals. In the cognitive data, we identified some problems, mainly in the language and some more complex tests that we used, the trial A, trial B. And it's also very surprising for us because most of the individuals had at least 15 years of school attendance. So we were not expecting so much problems for these people. And the third part of the in vivo study was related to the MRI analysis, in which we applied surface-based morphology. We used the UCL SPM12, and we extracted the individual's cortical surface maps, and we tested the difference between controls and these COVID patients. We identified some subtle areas of atrophy, and we are intrigued because some of these occur in the orbitofrontal region, as we can see here. And again, I stress these were non-hospitalized individuals almost 2 months after the diagnosis. We were interested to see whether or not all these structural abnormalities would be correlated with the performance. And here we can see that we identify some of these relationships. So trial B, poor performance associated with thinner cortex in the right gyrus rectus. So in summary, our in vivo data showed us that we saw most of the patients, they remain polysymptomatic even after 2 months. We identify some impairment in cognition and some subtle abnormalities in the MRI. Okay. So the second question, does the SARS-CoV can reach the brain? And for that, we analyzed brain tissue. So now I'm entering in the in vitro part of the presentation, which is divided again. And then I'll talk about right now about the brain tissue analysis. So we obtained the tissue using a minimally invasive autopsy via endonasal transethmoidal access from 26 patients who died from this disease. Okay. We identified some problems, some structural abnormalities, including necrosis, cytological damage, and also immunological infiltrate in five of these patients. We confirmed that most of these cells that were involved were astrocytes, and also we identified the presence of double-stranded RNA, indicating that the virus was replicating in these areas, in these cells. So from the tissue analysis, we identified SARS-CoV in 5 samples. We observed some areas of necrosis and inflammation. We also confirmed most of the cells were astrocytes, and we observed replication in these cells. Okay. Then the third question, how does the SARS-CoV reach the brain? Well, we don't know yet. This is I think it's a important question, but unfortunately we cannot prove, we don't have a good answer for that. And then we go to our last question, then what does the virus can do to the brain? So again, so we had tissue from this autopsy, and we performed a proteome analysis, which indicated again that most of the proteins were associated with the astrocytes, which goes along with the finding from the analysis we had investigate about the cells, okay? And the analysis of this proteome from the tissue indicated that most of the proteins involved were associated with carbon metabolism and also several neurodegenerative processes. Again, we don't know how the virus entered the brain exactly, and then we will continue to investigate what was happening in the brain. Because most of the evidence were pointing to the astrocytes, we decided to look deeper in the astrocytes' role in this pathogenic process. And now I'll be talking about this. So we generated astrocytes from stem cells and incubated them with the virus and analyzed the cell response after 24 hours. Again, we observed that the generated astrocytes, they were infected with SARS-CoV. And again, we identified the process of replication in these generated cells. Again, we analyzed the proteome of these generated cells and compared with the proteome we had analyzed from the tissue. And we observed that some proteins, some cycles were in common, and this involved the necroptosis and gluconeogenesis, glycolysis, carbon metabolism. So involved both metabolisms and the necrosis. The other part, we used another technique to invest further these astrocytes, and then we analyzed the metabolome. And again, it was interesting because the results showed that the astrocytes, they were facing problems of the metabolism, and we conclude from here that there was a remodeling of the astrocyte metabolism. So from the beginning of the analysis of the astrocytes, we observed they were infected and they allowed the virus replication. Additionally, we observed some problems with the proteome and the metabolome, indicating that most of these pathogenic problems were involved in the metabolic intermediates of glycolysis, and indicating that were extensive remodeling of this metabolism. Okay. So we observed increased metabolic activity in these astrocytes and also reduction of metabolites that were important for neuronal support. And then we decided to study what could be the consequence of these astrocytes? Whether the problem of the astrocyte would impact the neuronal viability. And then we performed the third part of this in vitro study, in which we analyzed the neuronal viability. So we tested whether the astrocyte would have any impact on neurons. So we used conditional medium of SARS-CoV infected astrocytes and incubated some neurons to see what would happen to these neurons. And it was interesting to see that the neurons that were incubated in this conditional medium with astrocytes infected, the neurons were suffering more increased ratios of apoptosis, and confirming that somehow the astrocytes would change the metabolism and the metabolites, and probably implicating in the cell death of these neurons. Okay, so in summary, from this point of view of the astrocytes, we proved that, we showed that the astrocytes were infected with virus replication, which probably altered the proteome and the metabolome of the astrocytes, indicating that extensive remodeling of astrocyte metabolism. And this probably evolved to a reduction of metabolites that were necessary for neuronal support and resulted in neuronal apoptosis. So this is the sequence that we were able to trace from our study. Okay. And so briefly here, I want to thank my team. So this is the in vivo study team. There's a lot of people that I need to thank. And this is also an in vitro study group. That is a lot of people from the other labs that also helped us to perform all these analyses. So thank you.
Thank you very much. Thank you, Clarissa. I will clap on
very brief,
everybody's behalf. Now that's a brilliant run through, because there's quite a lot, clearly quite a lot that you've covered there. And that was one of the things that attracted us. You've disappeared, I think. Let's have your camera back on. So we can discuss and get questions and comments from people. So please post any questions or comments into the chat. There are a couple there, but maybe I'll start, Clarissa, by asking you, I think you've disappeared again, actually. I don't know if it's a camera problem.
Okay, I'll try to open here. Yeah.
There we go. That's better. Yeah, I mean, it's a wonderful range of approaches to look at this problem with COVID and neurological disease. I was intrigued by the studies you showed looking at the surface-based morphology and showing subtle atrophy just 2 months after these patients were infected, and these were non-hospitalized patients. So for those studies, what are the controls that you're comparing with?
Okay, so for this study, we used controls that we had acquired MRI before the pandemics, because right at that time, we were not able to bring controls to the hospital. So we had to use those. We had hundreds of controls acquired before, so we used those. But now I have more actual controls, more recent controls. I was not expecting, because from our experience with MRI analysis, the gray matter is very resistant to insults. So I wasn't expecting to find anything. But these our results they have survived the multiple comparisons thresholds, and so, but they're very subtle. They're not very intense. So it's very different from other neurological or neurodegenerative disease atrophy.
Okay, thank you. Let's just feed in some of the questions from some of our audience. From Wandimu is asking about, during complicated COVID-19 infection, how do cells deprive oxygen till there's a supply with actually AR? I'm not sure what AR means. But can you comment on, do you think these mechanisms, do you think lack of oxygen is part of the mechanism here, the disease mechanism, or do you think it's all this proteome and metabolome changes following astrocyte infection?
as I told you, I am not an expert in these in vitro studies, but I think it's a mixed problem. I think there is something very specific affecting the neurons, but I think the oxygen problem may also be involved in some degree of ischemia or oligemia may be involved as well. This is from what I believe. So.
Thanks. Matilda Leonardi, who's one of our regulars, has asked, did the people that died and on which you performed the autopsies have specific neurological disorders different from others? Did any of them have stroke?
So I cannot tell. I asked it, but they were not able to trace back. So we don't have this information. Probably some of them, but maybe not all of them.
Okay, thank you. And then William Gilbert is asking whether you've tried the astrocyte neuron experiment using primary or stem cell derived neurons.
I think they only use it astrocyte derived, but the neurons they use it, I am not sure to tell you with 100% certainty. I know that the stem cell, they use derived astrocyte, but these neurons, I am not sure. I would have to ask Daniel.
Yeah, I think the ones you showed us are from it's a neuroblastoma cell line, if I remember correctly. But
I know they are adrenergic neurons, but I'm not sure which lineage they're coming from.
Yeah, but it might be interesting to do those with primary
I take
neuronal
notice.
cells.
Yes.
Yeah, the stem cells derived neurons. Okay. Somebody's asking about the implication of your findings for neurogenesis and the neuropsychological rehab. This is coming from Antonia Lentor.
Well, I myself have been infected with COVID in August, and I have been suffering with cognitive issues since then. Not since then, but after like 2 months, I have been very suffering a lot. And I hope that it will improve over time, but I have been taking some drugs to work. But I think only longitudinal studies will be able to tell us whether or not these symptoms and findings are temporary and we can recover from this. That's what we do. So what I showed you is a cross-sectional analysis, but now we are starting our second visit, our V2, and bringing back the patients to analyze everything again.
Ben's joined us. Ben's one of our co-hosts. Ben, what are your thoughts on this and any questions or comments?
Yeah, thank you. Well, congratulations, Clarissa. It's a great body of work. So well done to you and the team. I just wondered to what extent the astrocytic and neuronal changes you saw in vivo reflect the dying process, or to what extent you think they're directly related to the SARS-CoV-2 infection?
Well, in vivo, I don't think I have exactly showed anything like in vivo. We had tissue from the autopsies, but I think we cannot make this connection because we don't have data enough right now to. Everyone is asking, well, but what is exactly the correlation between the in vitro and the in vivo? I know there is a huge gap, but one interesting thing that I found that because when I analyzed the MRI, I performed a whole brain analysis without any a priori hypothesis. And surprisingly, the area in which I found some degree of atrophy was exactly above the nose. And then I asked the guys from the in vitro study, where did you collect the samples? And he said, well, it was performed this way. He explained to me. I said, well, it's a huge coincidence that everything happened in the same area, in the in vivo and the in vitro. So this is the only tip I have. That's maybe the entrance can be through the nose. And then we found some in vivo and then the in vitro alterations in the same area. But I don't have a good answer for that, unfortunately.
You mentioned the nose. Somebody, Juzar Hook, has asked how many patients had lost their sense of smell. Do you have that information on them?
At the acute phase, I think over 50%, like 50-70%, they mentioned they have lost the olfaction. But most of them recover, but not all of them. Over time, it seems for us that approximately 20 to 30% persist with abnormal olfaction. Not all of them recovered entirely.
Okay, thanks. And there's a question. We're getting some great questions and comments in from the audience here. Kennedy Muima says, did the autopsy rule out other comorbidities just to narrow it down to SARS-CoV-2 as the cause of death?
Yes. I asked the guys and they said yes. So it was really related to the SARS-CoV at that time. Yes, they confirmed it. It was related to that.
And someone called Ulises Gomez Pinedo is saying there's a relationship between the strains of SARS-CoV-2 in Brazil, so there's some of the Brazilian strains, and neurological involvement. Do you think your local strains are particularly likely to cause neurological disease?
I think right now with the new wave of patients, we have been seeing more neurological impairment. We have been called more times to the ICU, to the emergency room. We have seen a lot of, it was because I work at the ER, and then we have been seeing a lot of patients coming with neurological symptoms, and then we diagnose COVID, like convulsions, stroke, or transient ischemic attacks. We have seen much more neurological issues right now with the new, probably the new strain, the new virus. Yes, so I am very worried about, because I think I already had 7,000 entries in my link, and I believe it will have more, because I think people, they may be suffering more neurological problem with the new virus, with the new version of the virus right now.
And RT Pandit from the UK is asking whether these kind of neurological symptoms, should they prompt anything different in terms of testing for the virus, in terms of nasal swabs or antibody testing? Is there anything special we should be doing, or do we just test patients in the same way?
I think we should just test the same way. I think I don't see any difference to direct to guide.
I'm gonna, in a second, I'm gonna ask Ben to join us for a question which I know is in his area of interest as well. But let's just ask you this question from Maite Garolera, who's asking whether you find problems with the naming test, for example, the Boston naming test in the neuropsychological testing.
So it was not Boston, it was the fluency, verbal fluency with FAS test. So it was a simpler test. And it was more specific with the phonological test rather than the categorical testing. It was very interesting because they performed better in the categorical, but they were very poor in the phonological testing. Yes, it was very different. Yes.
Okay, so I mean, clearly you've you know, the hypothesis you've put forward is that this is all about the astrocytes becoming infected, and then the metabolome, the proteome changing, and then that impacting on neurons. There's a question from Jay Mohan Joseph, which I'll ask you, and maybe also see if Ben has any thoughts about this as well. Jay Mohan's asking, does the astrocyte infection impact on the endothelial cells and the blood-brain barrier, do you think? Do you think that could be an important part of the disease mechanism?
I think there may be a relationship, but we haven't tested that to prove. But as the astrocytes are related to the other cells, I think there may be, probably they are all involved, I think, but I don't have any proof for that.
Ben, what are your thoughts on that?
Yeah, so, you know, the neurovascular unit is complex, isn't it? And the work that's been done in the animal models looking at this is largely around this small degree of perivascular cuffs, which we've seen in other viral infections do correspond with a breakdown in the integrity of the blood-brain barrier. We've got a Mendelian randomization genetic study currently, which is under review, which showed that several of the matrix metalloproteinases were up in patients with severe disease. So that may be pointing to the blood-brain barrier being important, and your work adds further weight to that hypothesis.
Great. Okay, well, thanks. Well, Clarissa, thank you so much for that. We will let you rest now. I know it's quite early in the morning, actually, where you are, and some great questions from everybody. So let's move on now. And Darnish, if you want to turn there you are, you're on, and share your screen. So Darnish is at the University of Manchester. It's part of the JNNP blog team who keep an eye on all the journals and present for us the most recent and most exciting papers that they've come across. So Darnish, over to you.
Yeah, thank you very much. I hope everyone can see me, hear me, and see my slides. Hi then, as Tom said, my name is Darnish Hafiz. I'm a final year medical student at the University of Manchester, and I'm part of the blog team at JNMP. And today I'll be going through kind of 4 diverse papers that we've seen over the last month, which we think might be of some interest over the next 5 minutes or so. Just so you can see, you can contact us on Twitter on the bottom left, mine is on the bottom right, and also recently we've gained control of the Neuropsychiatry Twitter handle, where we generally talk about neuropsychiatry and the history of it, so please follow us and find out more there. So the first paper I've picked is by Pranata et al. And is a very interesting paper on delirium, and is kind of building on some of the things we've spoken about before, when delirium can sometimes be the only presenting symptom of COVID-19 in older patients. So in this study, they did a meta-analysis of almost 4,000 patients from 9 studies, and they found that, as other studies have shown, that delirium is very common, with 27% having delirium. However, the kind of shocking or outstanding finding was that they showed that delirium was associated with an increased chance of mortality in individuals with COVID-19, and this was almost double. And even when they adjusted for different variables, it was still associated with an increased risk of mortality. And the relationship between delirium and mortality didn't seem to be influenced by age, by sex, or medical comorbidities such as hypertension or diabetes or dementia. Now, I think this raises a lot of questions and is quite interesting. We aren't exactly sure how delirium might be caused by COVID-19. However, one of the findings in the study was that for every 1 milligram increase in CRP, there was an associated 1% increase in delirium. So maybe it could be something to do with how severe the infection is, something to do with the immune system and the inflammation that's going on. But that, remains to be kind of studied going forward. And also some of the drawbacks of the study was it was all retrospective papers, and they used lots of different delirium assessment tools. So we have to be careful about what we draw from this study. And I think it highlights, regardless, the importance of managing delirium in patients with COVID-19. And the authors argue about the lot of non-pharmacological interventions that could be made to help patients, and that might have an influence on mortality. And they caution using pharmacological things like benzodiazepines and antipsychotics, which might have a negative impact, and suggest using melatonin. And that's something that I think the research will continue to talk about. So the next paper that we've got is a preprint, and I've included it because it's quite innovative. I did find it a bit complex to read through, but I think it is worth discussing. So it was by Abdullah, and it was drawing on the UK Biobank. For those of you who don't know, is a large repository of data that's been collected from individuals in the UK, and it was they were able to access the MRI data of 3,600 or so individuals. And of these, they found that 921 were later diagnosed with COVID-19. Now, the interesting part of this study was that the imaging was done at least, on average, about 3 years before the individuals contracted COVID-19. So that way we know that the brain signatures that they were evaluating couldn't have been a consequence of COVID-19 and may have shown some predictive element. And they used a machine learning algorithm and to back translate and see what brain signatures were associated with COVID-19. And they found that certain functional regions, such as central executive and ventral salience connections, and others were associated with an increased later risk of COVID-19. Now, this doesn't show causality, but I think it does raise an interesting question about whether or not, we might be able to predict who gets COVID-19 and infections in general for future pandemics. And there's lots of discussion about why that might be. I think the author mentions it might be something to do with personalities, which makes individuals more likely to contract the infection or kind of genetic things as well. And that's something that, again, we will have to wait and see. So the next study is recently we've expanded our blog to include the neuropsychiatric effects of COVID-19, which have been reported quite topically in the media recently. And because of that, we think it's important that we include it within our blog as well. We understand that, you know, all the studies and trials that were done showing that it was quite safe, but there are still these reports emerging, and I think it's important to discuss. So this particular study was done on on healthcare workers in the United States who received the Moderna vaccine. And this was done through an online survey. And what it did show was that most of them, almost 98%, had at least one symptom post-administration. Most of these are quite non-specific, and the neuropsychiatric ones were things like headache, myalgia, and dizziness. Psychiatric effects were quite low, low mood being less than, being around 1%, and gratitude being about 5%. However, some patients did report other side effects such as difficulty sleeping and brain fog and confusion, and a small but important of 1 to 4% of individuals reported sensory changes around the injection site, such as numbness and tingling. So overall, it shows that it indicates that the vaccine might be relatively safe, but neuropsychiatric effects do happen. And there's a discussion to be had how much of this might have a relation with kind of functional neurological disorders and the effect of kind of expectation and beliefs and how that might influence individuals developing symptoms. However, despite all of this, most of the individuals taking the vaccine were happy to have their second dose. And we also have to be careful with the conclusions we draw, as most of the individuals were healthcare workers, and this might not apply to the general population. So finally, very quickly, I'm just going to touch on this letter about GBS by Castillo. And this one was that GBS is really observed in COVID-19, and it's seen as quite a rare side effect, and most of the studies that we have kind of gone through seem to indicate there's no increased risk of having COVID-19. However, they emphasize that the comparison in previous studies has often been on COVID-19 GBS rates compared to general population rates from the pre-pandemic era. However, since the pandemic has started, GBS rates in general have decreased due to increased hygiene and reduced other infections which can cause GBS. So therefore, we need to compare it to the GBS rates at the moment rather than pre-pandemic rates, which they argue are kind of closer to 0.42 per 100,000 rather than 0.89. And this kind of interesting data argues whether or not we should reopen the kind of discussion about GBS and COVID-19. And actually, they argue you need to compare it to the non-COVID-19. And in all of these studies, I think they've shown that the majority of the people who they did find with GBS did have COVID-19. And that brings me to the end of my presentation. You can see a picture of our team on the left-hand side and some of the work that we're continuing to on the bottom. Please do, if you're interested in getting in touch, we're always happy to have people. You can contact us on Twitter at neuropsychcovid, or you can email Tim Nicholson and let him know that you're interested. Thank you very much.
Danish, thanks very much for that. That's great. So we won't take questions at this stage, but we may at the end come back and discuss some of these issues. In particular, you've raised some real hot potatoes there, the side effects associated with vaccine, and then of course this GBS question. But let's move on now and hear from Professor Paul Harrison, who is a psychiatrist at the University of Oxford, and who's going to present these intriguing links with psychiatric disease. Thanks, Paul, over to
you. Good afternoon, everybody. Very nice for you to be joining this webinar. So yes, I'm going to summarize very briefly, in fact, not the paper that was in the title of Tom's, of the publicity for this, that was our previous paper, but our latest paper, which some of you may have seen, which is looking at 6-month neurological and psychiatric outcomes in almost 250,000 survivors of COVID-19. So this really supplants our previous paper, except that, as I put in the bottom, our earlier paper also looked at the reciprocal question, which showed that people with a psychiatric diagnosis were significantly more likely to be diagnosed with COVID than others. And that association survived our attempts to control for a range of socioeconomic and other factors, but that's not something we looked at in the second paper. And our next paper, which we may come back to talk about a few months to come, is looking more particularly at long COVID features. But this particular paper is looking at, if you like, the classic neurological and psychiatric diagnoses. And just very briefly, these are electronic health records, mostly based in the US. And these are the records of about 80 million patients, amongst whom, as I said, almost 250,000 had a confirmed diagnosis of COVID during the study period. And we really asked a simple question, well, two simple questions. What is the incidence of these neurological and psychiatric diagnoses in the 6 months after a COVID infection? And as you'll see in the next slide or two, we measured both any diagnosis and any first diagnosis. In other words, the any diagnosis means people who may have had the same diagnosis before, but are then diagnosed with having a recurrence. And any first means people who have not had a diagnosis in this category before COVID-19. And then, particularly relevant to today's focus, we looked at how the severity of COVID-19 affect these risks. And we compared people who did or didn't need hospitalization, did or didn't need intensive care, and did or did not have encephalopathy or delirium, relevant to Dinesh's paper he showed, during their COVID illness. And as well as calculating incidences, we calculated the hazard ratios compared to propensity score matched cohorts of patients who had a range of other conditions, as you can see down there, all happening contemporaneously with the COVID pandemic. So we tried to tease apart what the non-specific effects of the pandemic and the lockdown might be from the particular effects of COVID or the comparison conditions. Now, this paper and the appendix, there's a lot of data in it, so I'm just going to show, I think, 2 or 3 slides that highlight the kinds of findings we made. And then, again, I can either take questions or you're welcome to go to the articles. They're both available online, free of charge. So first of all, the kind of headline figures. These are the percentages of people in the 6 months after COVID who received one or other, or maybe more than one, neurological or psychiatric diagnosis. And in the left-hand column is the whole cohort of COVID patients. And you can see that almost exactly 1/3 of them received one or other diagnosis in the next 6 months. And 1 in 8 patients, or 12.8%, received a diagnosis having never previously had one recorded in their medical records. If you then read across the rows as the cohorts become more severe, you can see that the incidence of these diagnoses goes up quite considerably. So that patients who, for example, had needed admission to intensive care had almost a 1 in 2 chance of being given a neurological or psychiatric diagnosis during that time. So let me just drill down into what were the major neurological and psychiatric diagnoses. So first of all, picking the neurological outcomes, and again, these are all percentages with confidence intervals. And so of course, I'm not going to go through all these results, but you can see, for example, that the incidence of stroke and of nerve and nerve plexus disorders were relatively common in the whole cohort. But again, reading across, perhaps the main message is that the risk of getting one of these diagnoses in the next 6 months went up markedly as you had been more severely ill with your COVID-19. And so to highlight a couple of examples, if you had required intensive care admission, you had about a 7% chance of being diagnosed with a stroke in the following 6 months. And if you had had encephalopathy during this period, you had almost a 5% chance of being diagnosed with dementia. In these prime analyses, we only looked at survivors. So these don't take into account people who died prior to an outcome. But in the appendix, you can find a table which shows how the odds ratio or how the hazard ratio is reflected and the instances. It doesn't make a lot of difference, it just changes the exact numbers. If we then look at these psychiatric outcomes, first of all, the point to make is that the majority of the diagnoses, the 1 in 3 I mentioned at the beginning, are coming from mood disorders and anxiety disorders. So that's a lot of the morbidity. On the other hand, other categories like psychotic disorder were not that unusual. If you read across the rows in this instance, compared to the neurological outcomes, the psychiatric ones, particularly mood disorder and anxiety disorder, really show very little association with severity of the illness. The exception is psychotic disorder, which in a way is behaving more like a neurological disorder. In other words, the chance of being diagnosed with that did go up significantly if you had been more ill with your COVID infection. And apart from that, there's a dissociation, I think, between the neurological outcomes, which do scale with the severity of infection, and the mental health ones which don't. And again, one can speculate on the potentially different mechanisms that account for those relationships. Now, all I've presented so far are incidences. I think to understand these figures, you really have to understand the hazard ratios. How different were these risks from an otherwise matched population during the pandemic period? So let me just show you one example of the Kaplan-Meier survival analyses, where here we're comparing the risks of these diagnoses after COVID, shown in pink, with influenza, shown in blue, and the corresponding hazard ratios are shown underneath. And that gives you an idea of the magnitude of the risks. It's between about, in these examples, 1.4 and 5.2 for the hazard ratios of COVID compared to influenza. And I stress again, these are propensity score matched cohorts, so they're matched for age, sex, race, blood pressure, diabetes, all the other things we think are relevant risk factors. And then finally, if we say, how does the risk of COVID be affected by the severity of the illness? And just like the incidence ratios, the hazard ratios increase with the severity of COVID-19. So your risks of getting these outcomes are greater the iller you were. It's not just that the incidence goes up, the relative risks associated with COVID go up as well. So to summarize, again, a lot of findings I've gone through very quickly. In the 6 months after COVID, about 1 in 3 get a neurological or psychiatric diagnosis recorded in their notes, and 1 in 8 get their first such diagnosis. The majority of these disorders are anxiety and depression, but on the other hand, several neurologic and cerebrovascular disorders are not uncommon. These figures rise to almost 1 in 2 for those who are in intensive care and 6 in 10 for those who had encephalopathy during their illness. So this is driven mostly, this severity link is driven mostly by neurological and psychotic diagnoses. Most, not all, but most of the diagnoses were commoner after COVID-19 than the comparisons. Perhaps one of the exceptions that wasn't was Parkinsonism, and neither did we really find a clear answer for Guillain-Barré syndrome, going back to one of the papers that Dennis showed. On the other hand, most other conditions were commoner after COVID-19 with a hazard ratio of anywhere between 1.4 and 5.3. And lastly, of course, just to highlight, these are electronic health records data. They show associations, they don't show causation and mechanisms, and they're subject to the limitations of all research that is based on health records. I've got a slide where I can go into some of the strengths and limitations more, but I think in the interest of time, I'll probably stop there, and I'm happy to take any questions and give some clarifications.
Thank you, Paul. Thanks very much. I will clap on behalf of all our listeners around the world. That's superb data. Please post questions and comments into the chat function for Paul, or indeed for Clarissa if there's any more questions or comments about that, or indeed for Danish. Maybe Paul can start. I mean, the striking thing, I've looked at these data before, I think, when you presented them, and also the papers. The hazard ratios comparing COVID with influenza are really quite striking. And I guess the critical question is, is this something about the vaccine, the virus, or is it, I mean, when you're looking at influenza, I think you're just looking at pandemic. And so, one wonders how much of the psychiatric disease is related to the virus itself and how much is just the circumstances of a pandemic. And are there any ways you could try and disentangle that, do you think?
Yes, that's a very good point, Tom. I think particularly for the psychiatric diagnosis, I think these sort of explanations are clearly more likely to be important. It's impossible, I think, to completely take out that confounding. We did, for example, compare the rates with influenza in previous years. So we tried to kind of take out some of the atypical nature of flu in 2020. For example, it was rarer and it wasn't very bad by all accounts. On the other hand, it's worth highlighting that in order to get, these were people who'd had a medical diagnosis of influenza. So they at least in a sense must have had bad enough flu to have gone to a healthcare organization and had the diagnosis made. And I think that actually applies to all our cohorts. You had to have got yourself diagnosed with the index event. And we know, for example, in the community, there will be plenty of people who had COVID without even being diagnosed with it, some of whom may have ended up in the influenza group and vice versa. So I think it's, so those are the ways we have tried to address your point, but you're quite right. With medical records, we just don't have enough, if you like, socio-economic and general contextual information to really rule out alternative explanations.
Thanks. There's a question from Maite Garolera, just about the psychiatric symptoms. Were they collected through standardized depression and anxiety scales? And I guess the answer is going to be you don't know. It's just a psychiatric diagnosis was recorded.
Yes, correct. Perhaps the important thing to emphasize is these were ICD-10 diagnoses that one or other clinician must have made. These were not simply patients reporting symptoms, for example. So these data are very different to a survey, for example, where patients can choose to report things. And that brings both strengths and weaknesses. They were not standardized diagnoses, but they at least were diagnoses that a clinician felt able or required to make.
Yeah, thanks. From Angela Vincent, a friend of ours, you probably know her in Oxford. She's works on neuroimmunology. She's not clear whether these first diagnoses were after, or could they actually have been during the COVID hospitalization?
Yes, good point, Angela. They simply, in our primary analysis, they simply had to post-date the index event. So they could have been made a day after COVID. Again, in one of our many sensitivity analyses, we excluded the first 2 weeks after a COVID diagnosis to try and tease out that question. And again, the incidence went down a bit, but it didn't markedly change the gist of what I've said to you. So we think a lot of this is, if you like, post-COVID rather than intra-COVID.
Yeah, great. I can see people are raising hands. I just remind you, we don't do hand raising in these webinars. We ask people to post comments. So if you've got your hand raised, I'm not going to come to you. I'd rather you just post your comments if you don't mind. Juzar Hooker has asked, what's been the incidence of autoimmune encephalitis in this series, and were there any associations with severity of disease?
Right, I'm just looking at one of the data tables. The answer is I don't know about autoimmune encephalitis. Encephalitis as a whole, just taking that diagnostic category, it ranged from, it was 0.1% in the whole cohort, and that rose to 0.35% in patients in ICU and 0.6% of patients with encephalopathy. But how much of that was autoimmune, I don't know.
Great, thanks. Let's at this point, maybe Clarissa and Darnish and Ben, if you want to turn your microphones on just to join a slightly broader discussion. Maybe we should start with this issue of Guillain-Barré syndrome, because the data you showed, Paul, I think, showed that it was reduced compared with previously. Did I get that right?
No, so that may have been the paper that Danish was presenting. Our data showed, and again, I can read out the incidence, the overall incidence in the whole COVID cohort was 0.08%. That rose to 0.33% in patients in ICU and 0.48% in patients who had delirium. If we then look at the hazard ratios compared to the other conditions, this is where it got a bit messy. It was not significantly greater than patients with influenza, but it was significantly greater than patients with other respiratory infections. And it was significantly different in, I think, 2 out of 4 of the other conditions we compared it to. And I think that's why we said even a study of this size, I don't think can really answer that question convincingly.
Yes, I think it was maybe the flu bit that I saw.
Yes.
Does anyone else want to comment on Guillain-Barré? So Solander has also asked about any associations of COVID-19 with GBS. And clearly we've had the paper that was published in Brain earlier in the year suggesting no increased link. Ben or Clarissa, do you want to comment on Guillain-Barré syndrome?
Well, we have seen very few. I think last year we saw 1 or 2 patients related to the COVID, and we were expecting more, but we didn't see that many patients here as well. Because we had other problems, like other things that we saw a lot of Guillain-Barré related to other virus here, but we really didn't see much of this related to COVID here in my hospital.
Mm-hmm. Thanks. Ben, what's your take on this evolving story and these ever-changing data or contradictory data?
I don't think we'd be having this discussion necessarily if that Brain paper hadn't come out that was something of a curveball. But with pandemic as Darnesh alluded to, really, as with pandemic restrictions, people aren't going out and getting Campylobacter and enterovirus and all the other things that would cause them to have Guillain-Barré syndrome. So I don't think we can look at just raw incidence of GBS during the pandemic and not during the pandemic and draw those sorts of conclusions. Certainly, we've had plenty of patients with a temporal association between COVID and developing GBS that's neurophysiologically proven and in an appropriate recognized time frame. So it may be rare, but it seems that it is associated.
Forgive me, I'm just trying to remember the Brain paper, but I thought as well as looking at overall incidence, they tried to look at the relationship geographically between areas where there'd been a lot of COVID in the country and then how much GBS there was. The hypothesis being you would see more GBS following in regions that had a lot of COVID. So they had a go at that, but did they not disentangle it in that way?
But unfortunately, at least in the UK, where those data came from, the lockdowns were proportionate to the cases. So the very measures that would reduce your risk were happening in those same areas.
Shucks. Okay. All right. Let's just look at some of the other questions that have come in actually on the Q&A function. It's actually Mary Iris Andel, I think, has asked the same question I asked. Is the anxiety directly caused by the virus? Is it just a result from the fear of having it? And I think, Paul, you've sort of answered that in terms of as far as you can get.
Perhaps just the last thing to clarify, although Angela say the result overall was not significant, I'm just looking at one of our supplementary figures. And unlike many of the Kaplan-Meier curves, the comparison for Guillain-Barré looks like it's beginning to diverge at 6 months, whereas many of the other hazards are proportional or a tailing off. So there is just a hint that beyond 6 months, a Guillain-Barré signal might become significant. But that's reading a lot into a non-significant finding.
And is that 6 months after the infection?
Yes.
Wow. Okay. Well, that would prompt us to rethink what we understand about Guillain-Barré, I think.
But I say it's looking at a non-significant trend. That's all.
Yeah. Yeah. How has this is from Hardy Richter? How was COVID-19 severity assessed? Was there a correlation between incidence of mood or psychotic disorders and duration of ICU stay? That's for Paul, I think.
Yeah, sorry, we can't know that. Although the coding in this network is extremely good for some things. Things like duration of ICU stay, we couldn't get those data out of it. So all we know is that the person had at least, I think it was 1 night in ICU, but whether it was 1 night or 10, we don't know.
Okay, great. And this is one for the neurologist, I think, or anyone. Abantika Ghosh, is there a correlation between COVID-19 and increase in ADEM, acute disseminated encephalomyelitis cases? Maybe people could comment what they've seen clinically. Or Paul, I'm guessing you didn't see a signal for that at all in your data.
I don't even remember the ICD code for it, I'm afraid.
No. Anyone want to comment on, Danish, have you come across publications on ADEM in your JNNP blogging?
I can't remember any off the top of my head. No, sorry. Okay,
no worries.
Yeah, so I think there've been a fair few cases now published of ADEM, at least in a temporal association with SARS-CoV-2, and the challenge with the coding, as Prof Harrison mentions, is that you are reliant on the coding and things can be coded differently. And ADEM is particularly difficult because it's often coded as transverse myelitis or ADEM or myelitis or clinically isolated syndrome or demyelination. So I think it's hard to do it, but certainly we've seen it clinically.
Here's a question for, I think, back to Clarissa, and we'll have to finish shortly, but it relates to the findings, Clarissa, that you presented. And Abantika Ghosh has asked, has any recent immunotherapeutic approach been shown to be effective against, well, viral CNS entry, she says, but ultimately leading to tissue damage? Do you want to comment at all on your findings, the immune response and potential implications for therapy there? You're muted, actually, Clarissa.
Well, I don't think we have evidence to propose there at the time. We are doing all this research, everywhere. I think we are trying to find the best targets. It may be the solution for some cases. We have seen some encephalitis here related to the acute stage, and then we have corticosteroids or immunoglobulin. But I don't think it can be extended to everyone. Like we had one young lady, she had a previous autoimmune encephalitis, then she had COVID in January, and now she is very, very bad. She's really, she regressed a lot. She's 15 years, and we are bringing her back to see whether the seizures and everything, we are probably proposing immunotherapy for her for a long time, because she really had a very bad time, and she is really cognitively, motor, everything is really bad for her. But I don't have answer to propose this in a large scale, not yet.
No. Okay. All right. Well, thank you. We're going to stop there so that we finish on time. Among the JNNP blog, Danish was talking about some of the vaccine adverse events. Of course, there's been a lot of activity in this space. And in our next webinar, which is on the 18th of May, we're going to have a special on vaccine adverse events, in particular thrombosis and thrombocytopenia, which of course is very topical. But let me just thank all of our speakers today, Clarissa, Danish, Paul and Ben, for additional input.